Welcome to ATCM, the Emergency Medicine Channel. A 21-year-old male was brought to our ER with complaints of difficulty in having food, dysphagia, stridor. That's how he was presented to outside hospital, following which he was intubated in that hospital and then referred here for further management. On initial 10-second assessment, patient airway was already, intubation was intubated, there was no secretions, airway was secured. Coming to breathing, patient was having a respiratory rate of 20 per minute, saturation with 21% FiO2, he was maintaining 100%. Circulation wise, BP was 130 by 80 with a pulse rate of 118 per minute. Disability wise, he was obeying commands. GCS was E3VTM6. Exposure wise, temperature of 97.6 degree Fahrenheit. Now, coming to adjuncts to primary survey, we had taken an ECG, we had shown a sinus tachycardia and taken an ABG. ABG showed no acid-base imbalance, creatinine was 0.9, lactate was 1.2. There was no, and potassium of 3.3. Then coming to sample history, a 21-year-old boy complained of abdominal pain at night around 12 am, following which he was given paracetamol tablet by his parents. But since pain persisted, he was taken to outside hospital, where on the way he had one episode of tonic-clonic movements, which lasted for around 3 seconds, followed by patient got agitated. Patient developed drooling of saliva, dysphagia. When he presented to the hospital, they documented as patient not having neck holding and patient developing stridor. In view of impending respiratory compromise, airway compromise, patient was intubated from outside hospital and referred here for further management. On arrival here, on examination, patient was conscious, patient was understanding what we are saying, but patient was unable to move all his upper limbs as well as his lower limbs. He could only move the fingers of his hands and the fingers of, and the toes of his legs. So via that we could communicate with the patient. We could ask as in yes no. He would reply to leading questions, whether in yes no. So in checking the tone, patient tone was decreased. Patient was in hypotonia. All muscles were flaccid. Plantars bilaterally, it was mute. At that point of time, patient had no, on asking to bystander, patient had no history of any drug abuse, had no history of any recent any bite, any insect bite or any snake bite. There was no any distinct fang mark seen on his body. We gave a neurologic consultation for the same in view of early GPS, suspecting early GPS descending paralysis, or also
early GPS descending
ascending paralysis.
I told descending paralysis.
Descending paralysis because
where you get that?
Descending paralysis.
Descending paralysis is a feature of what is the variant called? Miller-Fisher variant. What are the DDs? Descending paralysis. Miller-Fisher variant of GBS is the most important. Then
botulinum toxicity.
Okay, then
Strychnine poisoning.
Okay.
Lead poisoning can lead to flaccidity.
No, that takes time. It is a sensory neuropathy, motor sensory neuropathy. Tick bite. Okay, these are the common things. Okay, that snake bite also can happen. Okay.
You gave a neuro consultation in regarding the same. Then after some time, bystanders went back home and they actually found a crate in that home. Then we thought that patient most probably got a snake bite, and so we admitted the patient and started the patient on anti-snake venom. 30 vials of anti-snake venom were given to this patient.
Okay. How do you give anti-snake venom?
Anti-snake venom usually is come in the powdered form. So each vial we have to mix in sterile. We mix with sterile water of 10 ml. So each vial gives 10 ml. So 10 ml we take 10 vials together, that is 100 ml, and give it within 1 hour.
Okay.
That is 1 to 2 ml per hour.
Each vial should be given over 10 minutes.
10 minutes. Each vial over 10 minutes. So total in 100 minutes we finish 10 vials.
Okay.
And we can repeat the same dose up to maximum up to 30 vials.
Okay.
So we started the patient on.
Is test dose required?
Test dose cannot be given in anti-snake venom because it is usually a complement mediated pathway, not an IgM mediated pathway.
Okay.
We keep ready adrenaline and then we give the snake.
What are the common side effects of ASV?
Usually it will cause allergy anaphylaxis.
Okay. So what will be the clinical finding?
A patient
Common
will-
clinical finding
patient
during
will
transfusion. Breathing difficulty can be there.
Breathing difficulty.
Hypotension is the most
hypotension.
important side effect. Okay.
Arrhythmias
Breathing
develop.
difficulty can be there. Arrhythmias are not very common. Hypotension, breathing difficulty, itching, rashes.
Swelling. Then we started the patient on ASV. Also, since suspecting crate bite, which is actually a presynaptic, it will basically inhibit neurotransmitter release from presynaptically. That is basically it will release the inhibition of release of calcium, which eventually goes and stimulates the muscles. So because of that inhibition, patient goes into flaccid paralysis. So we also started the patient on calcium gluconate. And that is 10 ml, 10% every 6th hourly we were giving, and also monitoring the calcium levels of the patient. And
Postsynaptic bites, which are the classical examples?
postsynaptic is cobra bite.
Cobra. What is the treatment for that?
We have to give neostigmine with. We have to intubate the patient.
Yes.
Intubate the patient, and we can give a trial of neostigmine and atropine.
Atropine and neostigmine, or neostigmine and atropine? Which one will you
First
give?
is atropine, then we have to give neostigmine. And then
Why it is like that?
Because
Why atropine first?
bradycardia.
Side effects like?
Bradycardia. Neostigmine. Then patient, since patient is already intubated in our case, so we monitored the patient for improvement of his muscle power. It's around 5 days of his admission, and now patient has improved. He is initially only finger movements were there. Now he can move all his upper limbs and lower limbs up. The only part is like his neck holding has improved. Most probably by tomorrow it will improve, and we are planning on extubating our patient.
Okay.
So coming to
if you don't give ASV, what will happen? Suppose you are not getting ASV due to some reason, patient is intubated. What will happen to the
it
patient?
will improve
Patient
eventually.
will improve. Definitely patient will improve, but it takes longer time. Okay. When we have ASV, it will shorten the period of mechanical ventilation.
It will basically bind to the circulating venom and decrease the load.
So it's already attacked and patient has developed weakness. So it can, ASV can only neutralize the circulating venom. So this already
is binded,
it will be very difficult. So even if you cannot give ASV due to some reason, ideally we have to give ASV. If you don't get also, mechanical ventilation alone can save the patient.
And so coming to snake bites, usually we have the big fours. The big fours consist of
Big 4 or big 5?
Nowadays big 5, Humnose pit viper is also included. So usually the big 5 include the Elapidae, that is the common cobra, common crate, and then Viperidae, that is soft scale viper, and the Russell's viper. Now including the Humnose pit viper, it becomes the big 5.
King cobra?
King cobra, Indian cobra. King cobra is not in big.
It is a different
Indian cobra
snake, and which is more dangerous, cobra or king cobra?
King cobra. King cobra.
Cobra is more dangerous. King cobra is not furious. It will not attack anyone. But cobra attacks repeatedly. That injects more venom than king cobra. But venom wise, king cobra maybe it is not superior. It is all same.
Coming to snake venom components, it contains 90% of proteins like enzymes, hydrolase, hyaluronidase, then zinc metalloproteinases, which basically goes and damages the endothelium. Then it contains procoagulants, which basically make the patient more prone to develop DIC. Then
so when you have a bite, how do you know that it's a dry bite or poisonous venom is injected? You know what is dry bite?
Dry bite when the venom has not been injected, but
so how do you know that?
Bit. Local signs of envenomation.
So local signs are very important. In a snake bite, whether it is a poisonous or non-poisonous, if local swelling is there, that indicates snake has injected venom inside the human body. That is producing a local reaction. So that is very important. Next one, what is the next sign? If the venom is injected, first is local reaction. But in crate, it is very, very minimal.
Then tender lymphadenopathy.
Tender lymphadenopathy. The third one, this fellow had, that's why I'm asking.
Ptosis.
Before that, he complained something else.
Pain, abdominal pain.
So, local reaction is very important. Local lymphadenopathy, painful lymphadenopathy, second thing. Third one is abdominal pain. These are the common clinical finding in almost all snakes. But crate, unfortunately, we don't see any bite marks. We don't see any local swelling. Okay, so that is a problem in this case also.
Then this snake venom also contains phospholipase A2, and then postsynaptic alpha neurotoxins which bind to acetylcholine receptors, and presynaptic beta neurotoxins which damage the nerve endings. Then coming to local symptoms, usually there will be fang marks which may not be seen in crate bite because usually these are hypodermic bites, so we might not see. There will be local pain, bleeding, inflammatory changes will be there, blisters, lymphangitis, local tender
So
lymph
common
nodes.
in which type of snake?
These are vipers.
Viper.
Viper will be common. Then they can lead to further necrosis or compartment syndrome of the same limb.
How do you know compartment syndrome?
Rapid swelling will be there, disproportionate pain and swelling.
Pain disproportionate to the swelling.
Will be there. Then it can also have systemic symptoms. Systemic symptoms, most common abdominal pain and vomiting. Usually patients bit with crate will have abdominal pain, vomiting, followed by bleeding tendencies can be there, mostly seen in viper bites. Then ptosis, ophthalmoplegia. And a neurological weakness, there will be usually seen in crate or cobra bite, as well as Russell's vipers we can see ophthalmoplegia. Then myalgia, stiffness, tenderness, myoglobinuria can be seen, usually in snake bites, sea snake bites.
Myoglobinuria is very common in sea
Snake bites. Then a patient can go into renal failure, rhabdomyolysis,
renal failure is common in which all snakes?
Scale viper and hump nose pit viper.
All vipers it is very common, even sea snake also it is common, not in cobra and crate.
Then patient sometimes can go into pituitary or adrenal insufficiency,
which
especially in Russell's. It can bleed, pituitary bleed it can cause.
What is that syndrome called as?
Sheehan syndrome.
It is basically described in pregnancy, but same thing, pituitary bleed. How do they present pituitary bleed?
Hypotension, hypoglycemia, hyponatremia.
Then male and female, what is the difference? What hormone deficiency? You have to support the patient. Testosterone. So if there is a young patient, they'll have testosterone deficiency. Long term you have to give testosterone. Female also same like that. Growth hormones, everything can be deficient.
And sir, towards like how to diagnose which snake has bit a patient, we usually follow a syndromic approach.
Okay.
We might not need to know what snake, like we might not need to know what snake has bitten, but according to the symptoms, we can classify it according to some syndromes. So syndromic approach consists of 5 syndromes. So syndrome 1, if the patient has local swelling with that bleeding tendencies, bleeding disorder is there, we will suspect usually vipers.
Okay.
If second syndrome, local swelling, bleeding disorders, plus the patient has presented in shock with renal failure, we will suspect vipers.
Okay. Can you get shock in all other snake bites?
Yeah, shock can develop
shock in all snake bites, including heart attack, stroke, everything. That is due to the
initial tension.
Initial vasovagal syncope can happen because of this bite fear. Patient can develop tachycardia, heart attack, stroke, everything is possible.
Then if with ptosis, if local swelling bleeding disorder, with that if patient has ptosis, external ophthalmoplegia and weakness, then Russell's viper we have to suspect. Then syndrome 3 is local swelling, ptosis, external ophthalmoplegia, facial weakness with fang bite is also seen, then cobra we have to suspect. If there is no local swelling, no fang bite, usually bitten while indoors and sleeping on the floor, history is there. With that ptosis, external ophthalmoplegia with weakness, then we have to suspect crate.
This patient.
Then syndromic approach 5 is where there is dark brown urine, there is renal failure with paralysis, and a patient was bitten on land, we suspect Russell's viper. If in sea, we suspect sea snake. Then coming to the treatment of the patient, initial phase we have to give first aid. We have to first reassure the patient who is very anxious, then immobilize the limb, and also we can have apply pressure bandage. Tourniquets are to be avoided, but pressure bandage like crepe bandage can be applied.
The thing is, we get always a patient with tourniquet. So you should know how to remove that also.
Okay. Sudden release of the tourniquet should not be done because that will release the venom suddenly into the blood supply. So we have to tie a BP cuff higher than the level of the tourniquet and increase the pressure to more than the systolic pressure, then slowly remove the tourniquet and deflate. So
put a pressure bandage above the tourniquet, slowly release it. If possible, try to give anti-snake venom before removal of the tourniquet. That is also very important. Otherwise, what will happen? You remove the tourniquet, what will happen to the venom? Suddenly it will gush into your circulation. So before that, if we can try to give ASV. Otherwise, it's okay.
Then we should not interfere with the bite site and transfer immediately to any nearby hospital, especially those have anti-snake venom where availability is there. Then coming to investigations, usually we go ahead with 20 minutes whole blood clotting time, or if PTINR is available, we
Which is
go to
better?
the PTINR is more better if it's available, because PTINR usually will detect even if there is 10% decrease in the value of our clotting
Coagulation
factors. But whole blood clotting time will detect only after 40% reduction has already happened. So in whole blood clotting time, we need to take a clear glass vial, take 2 ml of blood, put in the clear glass and make it wait for 20 minutes, following which we need to turn it upside and see whether it has clotted or not. And then we can repeat it every 20 minutes till we get an INR value.
Okay.
Other investigations we can take at home WBC, like a complete blood count, and we can see elevation of WBC in that. Then we can also see for
APTT,
platelets.
should we do APTT in these patients?
PTINR.
PTINR is correct. Any patient
PTT suspecting DIC, we can
yes,
do.
some patients like viper bite may go to DIC. In that case, if we can do APTT with fibrinogen levels, it will predict whether the patient is going to DIC or not, especially viper bite.
Then we can also do the hemoglobin of the patient. In case of Russell's viper hemoglobin hematocrit, we check platelets also, because bleeding tendencies will be there. Patient might go to DIC. Then in case of C snake bite, if you are suspecting, we do a serum CK, which can be increased. Rhabdomyolysis and myoglobinuria can be present. Then viper snake, creatinine, renal injury can be caused. So we see for the creatinine, and also for hyperkalemia and rhabdomyolysis.
Amnospit viper?
Amnospit viper can cause rhabdomyolysis.
Same like a viper. It produces renal failure, and renal failure will be very prolonged. Okay, may take months to completely recover from that problem.
Then urine analysis for myoglobinuria we can do, and is suspecting DIC fibrinogen levels.
Okay. What is the difference in treatment? The elevation of PTINR alone and elevation of PTINR, APTT, low fibrinogen?
If only INR is elevated, we can treat with FFP.
What is the dose of
15 ml per kg.
Okay.
But in case of DIC, we have to give cryoprecipitate also to the
along
patient,
with
FFP. Okay. So that will be every 10 kg, 1 to 2 units every 10 kg body weight. Then coming to snake venom. Anti-snake venom, we will have to take each vial will reconstitute into 10 ml. So each vial comes to 10 ml. So 10 ml. Together we take 100 ml and then we give it 100 minutes, that is 1 ml per minute, maximum at the rate of 2 ml per minute. We'll have to keep adrenaline ready before we start the snake venom.
Is there any difference between small snake and big snake? Same family?
No, sir. Venom, no.
Which is more dangerous? Small or big? Small is more dangerous. They bite. They inject more venom. Okay.
And sir,
so there is no, but finally there is no difference in treatment. Okay. Whether you are bitten by a small snake or big snake, the treatment is same. Okay.
Then some clues of severe envenomation when we suspect, if like rapid extension of local swelling, and then early tender enlargement of lymph nodes, then nausea, vomiting, abdominal pain, hypotension, and spontaneous bleeding. If patient has developed ptosis, ophthalmoplegia, dark urine, reduced urine output, kidney failure, and low single breath count, then we suspect this thing.
Is there any difference between treatment of children and adult?
No.
Young child and adult, dose is same?
Dose is same for both. ASV we don't have to give test dose. Then adverse effects of ASV, usually early anaphylaxis can occur, angioedema, hypotension, shock, bronchospasm. Patient can also develop fever after 1 to 2 hours of treatment.
Any antibiotics are required?
If patient goes into compartment syndrome,
any antibiotics are required or
usually regularly not required.
It is not required. Ideally, it is not required. If at all, if you want to give what coverage you want to
Gram
give.
positive.
Gram positive and?
Gram negative. Gram positive and anaerobes.
Any bite, what is the coverage?
Gram positive.
Anaerobes.
Anaerobes.
Especially animal bite, whether it is dog bite, cat bite, snake bite, anaerobic coverage has to be there. Tetanus?
Yes, tetanus profile association.
Okay.
Every patient.
Is it a medical legal case?
Snake bite.
Yes or no? Will you make it medical legal or not? Hmm?
Yes.
Yes? It's a medical legal case. You have to document everything properly. So there is a chance of knowingly
Somebody.
done by somebody else. Okay. So that you have to make it a medical legal case, document everything in detail.
Then coming to atropine neostigmine test, usually done for only suspect if we are suspecting neurotoxic snake bite.
Especially cobra,
Cobra
not
bite,
in
not in
crate.
crate bite. It will usually won't help. So we give atropine 0.6 mg for adults and 50 microgram per kg for children. And neostigmine is 0.02 mg per kg for adult and 0.04 mg per kg for children.
Where
If-
else you use same test?
Myasthenia.
Myasthenia.
So if patients are responding, then we can put them to 0.5 to 2.5 milligram every 1 to 3 hours if the response is there.